Thank you, Dr. Aimee Gardner, for talking to us the Op Report today. Tell us, what learning theories predominate in our surgical training as it exists today?
Yeah, so off the cuff, I can think of, a few learning theories that are thrown around kind of the surgical education world pretty often. One thing that I learned very quickly upon entering medical education scene was people love adult learning theory. This idea from Knowles that learners are self-directed and have individual experiences, and people learn when it's relevant. They need to know why, and intrinsic motivation is critical. I've honestly heard that more in probably my first month in surgical education than I heard in probably 5 years of actual training in grad school. But it's interesting that people love it and they embrace it. It kind of has a lot of critics in that it may be too idealistic, but I think it's really valuable, whether or not you take it as like an actual theory or a teaching method or philosophy, or maybe even all of the above. So that's always a good starting point, I guess, is just to consider, the characteristics of the learner themselves, and they all are kind of unique. So I think that's valuable. Obviously the Dreyfus model of skill acquisition is really important, and I think it's increasingly become important as we think about how we might reform.
What's the Dreyfus model?
Yeah, so it's basically just learning through stages. So people come in, they're novices, and then they progress to advanced beginner, to becoming competent, to proficient, all the way to expert. And people use this a lot for the creation of simulation centers and skills lab, and just the idea that you can learn best by practicing a procedure or a skill, kind of at your own pace and progressing through all of those stages. And then, yeah, go ahead.
So teaching surgeons who are teaching trainees, in my mind, I don't see them as necessarily thinking about theories or anything, but just doing what was done to them when they were learners. So what theories or practices are they using predominantly, and are these effective?
Right. So I think one thing that we all can agree on is, like you said, people teach how they were taught, and kind of as a result of that, there's so much variability. And there's not really a uniform skill set that all of our surgical educators have. So they kind of pick things that they like, pick things that kind of flow well with, their personality, their characteristics. And I think it's interesting that we often bring in surgeons as faculty, but we often neglect to teach them really efficient instructional techniques.
Right.
So I think that's why surgery programs are really looking outside of surgery, right, to bring in people like me and people with other skill sets to kind of help complement all of these efforts.
Explain to viewers of the Op Report your role and your position and what you do with the residency.
Right, so I work at UT Southwestern in Dallas for the Department of Surgery, General Surgery, and my job is kind of split. So 50% of my time is spent with the program director group, helping design, evaluate curricula for our learners. So that's both our residents when they're going on different services, rotations, making sure that they're learning things, like making sure that we're assessing how they're learning, making sure all the ACGME national mandates, RC requirements are met, and then also making sure that the med students who rotate through on their clerkships are actually benefiting, and we're kind of optimizing their time as well. So we have the med students, we have the residents, and then part of my job in that, with that hat, is also faculty development. So equipping our faculty with these instructional theories, with these kind of skill set that they need to make sure everyone else is learning. So that's kind of half my job. And then the other half is research, and I choose to spend that time in our sim center. So I like to do kind of simulation-based training, more for kind of non-technical skills, but technical skills, team training, kind of some interprofessional training as well. So that's my job.
Okay, great. So as I mentioned before, it sure sounds like something every residency should have is a Dr. Gardner. All right. Tell me some things as you observe how students and surgical trainees are taught. What are some things you wish the educators understood about educational theory?
Yeah, I guess one of the primary things is that there's not just one educational theory. Learning isn't really a one-size-fits-all situation. So of course there's some basic concepts that for the most part are really applicable across kind of situations and tasks, kind of like feedback, the importance of goal setting. But even these really have idiosyncrasies that can vary from situation to situation. So, for example, we just gave a talk at Surgical Education Week about looking about how not all goals are equal for all levels of learner. And some of them can be really optimized if you're trying to make sure that the educational environment is really going to foster learning. So, even those kind of basic rules of goals are good motivators, good directors of effort. They're going to kind of create optimal learning environments. It's not always true. Learning is actually pretty complex. And I think that's why it's become more commonplace for surgery departments to, seek expertise from folks outside of medicine. So, learning often depends on, what skills being taught, the characteristics of the learner, the interaction between the learner and the instructor. And so those dynamics can really create very different learning environments. But I think that, if there were just one concept, one theory that was the solution to every situation, the world of surgical education wouldn't be nearly as fun. So I kind of actually appreciate that.
Good. So if you could redesign surgical education and resources were no object, how would you go about best training surgeons quickly?
Yeah, so that's a great question. I think we're all kind of seeing that there are increased pressures among surgical educators. The patient safety movements and the work hour restrictions, the criticism of kind of traditional methodologies like this apprenticeship model, the new techniques, new technologies is really kind of forcing a lot of drivers for this kind of revamp. And the quality expectations have really increased. So if I were going to kind of redesign it, I think I would start backwards. I would look at, what do our graduating general surgery residents need to know? And then I would kind of base the curriculum on that. So it'd be very kind of goals, outcomes driven. And, we'd be able to say by the end of your PGY 1 year, you need to know these diagnoses, these operations, these techniques. And we're going to kind of strategically place you in a variety of simulations and clinical situations. They're going to help you foster those skills. And we're going to have these intermittent competency checks throughout to make sure you're learning what we want you to learn. So it'd be, purely competency-based, lots of assessment, and not just this kind of time on duty with these services, rotations, or a certain number of cases. Right. And it'd be, kind of an idea of, once you've mastered what we expect you to master, and you're able to demonstrate that, then move on. So it'd be a very customized learning process. Mm-hmm. Possibly a horrible logistical nightmare for large training programs like us, but in an ideal world, that's what it would be. And to kind of complement all of this restructuring, I'd put something in place to ensure that our faculty are equipped with a solid foundation of skills in teaching and evaluation, so that there'd be an equal amount of faculty development to aid in all of these efforts as well.
Yeah. So who are trying some of these things? I know Canada sort of leads the way in some innovations in training.
Right.
Where in the U.S. Do you see interesting things being tried?
Yeah, so that's interesting. There's sprinkles of stuff going on everywhere. Definitely Canada, they have a lot of things figured out. Across the pond over at London, Imperial College, and now King's College, they're doing a lot of stuff. But even like in the States, WashU with Drs. Klingensmith and Brunt and AWOD, they're doing some really cool stuff. Over in Seattle, University of Washington, Dr. Pellegrini, Andy Wright, they're doing some cool stuff. And then, you of course, have to acknowledge Boston, the whole mecca of Boston. I won't even name one hospital because they're all doing great stuff. But, there are a lot of cool places that have, it seems like when 2 or 3 people interested in surgical education come together, they inevitably have really good output from that. So we just kind of all have to find each other and collaborate.
Absolutely. All right, last thoughts you want to leave us with?
Yeah, I would say it's an exciting time. Lots of changes, but with change comes opportunity. So I think if we continue to kind of borrow from other industries, other people who have kind of gone through this similar process, regardless of what they're teaching, what they're training, I think we can learn a lot. So we have to continue to kind of look aside to our friends, but also look forward. And it'll be a fun time.
Absolutely. Thanks a lot, Dr. Gardner. And I hope to talk to you again another day.
Perfect. See you soon, Chris.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurg content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurg.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.